Now we're going to move on to the second half with our international presenters, and as you'll see, there will be a convergence of themes that will lead to some great discussion after the next three presentations. So our next presenter is Adhi Nurhibadyat, is that right? And it's close anyway. Close. You'll tell us exactly how to pronounce your name when you come up here. And he's going to be speaking on the introduction and use of methadone to treat opioid addiction, and also for HIV and Hep C risk reduction and actually transmission reduction in Indonesia. So really looking forward to hearing about that.
Thank you. First of all, I would like to thank NIDA CTN, especially Dr. Petra Jacobs, and the organizer, ETOD, for inviting me for this pre-conference. I am Adi. My name is Adi Nurhidayat. I'm psychiatrist from Jakarta, Indonesia. I work with some researchers from Penn, George Woody, David Metzger, and from Yale University, Marek Czawarski. So today I will present the drug situation in Indonesia, treatment modalities that we have now in our country, Methadone Program, what's the meaning of running Methadone Program in Jakarta especially, and we do have the study collaborate between University of Pennsylvania and Ministry of Health in Indonesia, and other drug studies in Jakarta. So as you may know that we have like 240 million people, and since this is archipelago, we have, I count last night, it's like 18,000 islands. So with 6,000 with population, so it's we have a big problem with drug use in our country, because it's a big country and we have 600 languages and cultures. So I start with the drug situation begin in 17th century. Under Dutch colonialism, so we do have problem with opium, and by the early 20th century, we became one of the, how to say, home base of opium production. Lots of opium plantation in Java Island. So this is a picture from one book written by Ian Rush. It's Opium van Java. So this nowadays we have estimated number of 3.8 million drug users, all kind of drugs, 100 up to 200,000 are injecting drug users, mainly heroin. So this is estimation number by NNB this year. This one, household survey 2007. So if you see that we have problem with cannabis, ecstasy, methamphetamine or shabu, heroin, and benzodiazepine. This is in some part of Jakarta, Indonesia, and I work with them for the last 18 years. Drug users, heroin drug users. So 2009, we have a map estimated of aid youth is all over the country. So we have problem with budget airlines, because it transmit not only people but also drugs. So it's very easy from injecting heroin in the morning in Jakarta, and then move to Sumatra Island at noon, and then the next day you inject in Bali. So it's very easy to get the drugs now, especially lots of budget airlines now. So you can transfer not only people but also drugs. Almost half of IDU has multiple sex partners. The latest data show that one drug users can have 6 sexual partners. So it is data from the 5 big cities in Indonesia. This is our hospital, drug development hospital. Medical record show that we have problem with opioid. Regarding HIV/AIDS, we have reported HIV cases 108,000 and around 35,000 under ARV. We provide antiretroviral for free for first line, but for the second line, only half of them for free, and the third line out of pocket. So patient have to pay for the third line of ARV. These are treatment modalities in Indonesia. We have detox, methadone, Suboxone. In the past, we do have Subutex, Buprenorphine only, but since lots of diversion, so we moved to Suboxone, but still they inject Suboxone. So this is also a problem now. We have inpatient and outpatient settings, and some of them have hospital-based TC. In the past, we learned from day-top approach, but nowadays, since many medical conditions, we try to mix between day-top approach and medical approach. So hospital TC, we have nationwide. Additional treatment for ART, anti-tuberculosis, and for opportunistic infections. So this is methadone in Indonesia. Start in 2003 because the results of the study from several countries in Southeast Asia. So we did a pilot study, and it's success. So based on that result, our government started this methadone program. And this is number of clinics. Start from 2006 up to nowadays is 85 clinics nationwide. So this start 2003, and nowadays we have 85 clinics, including 9 inside the prisons. So we also provide a methadone program inside the prisons, around 2,500 patients. So this is one of the community health center that we provide methadone inside that community health center. So it's kind of trial and error actually in the beginning, but our government declared that we have to start, and then we use this already established community health center. This some of the methadone clinics in Jakarta. Some of them George Woody already visited the sites. This is our hospital. We are supervising another 12 satellites in Jakarta, including some prisons. So this is methadone clinics. We also provide group therapy for methadone patient. And since I'm the clinical coordinator, at the drug dependent hospital, we also have satellite meetings every 3 months. So it's kind of supervision between the hospital to our satellites. So this is actually lots of pros and cons embedded into already established community health center. So it's kind of putting the new treatment, methadone treatment, inside the already established health system. So in the beginning it's very hard because many rejection even from the health provider, because how to mix between the drug user with the general patient who come to the daily routine community health center. So in the beginning it's very hard to mix this. So this methadone user society in Jakarta, they are not methadoners, but the researchers that visited some sites. So this is our study, R01 NIH funded project. We collaborate with Penn and Yale University because we use some of the instruments, especially BDRC for drug and AIDS counseling approach from Yale. The number of the participants are 276. We involve 5 methadone clinics all over Jakarta and for 4 years. We just finished last week, so I do apologize that I don't provide lots of data analysis because just finished and resumed last week. This the title, Efficacy of Drug AIDS Counseling Among Injecting Drug Users at 5 Methadone Clinics in Jakarta, Indonesia. This we involve the patient who come to 5 methadone clinics in Jakarta. We divide it into 2 arms. First arm is intervention with BDRC, behavioral drug risk reduction counseling. So this and the other, the second arm is methadone treatment as usual. What does it mean? It means that it's usual. You just come to the counselor on demand. But in the first arm, you will visit, you will meet the counselor every 2 weeks. So it is different between the first and the second arm. So we collect the data every 6 and 1 year. So this follow up after 6 months and 12 months in both arms. So for treatment as usual, regular MMT, so methadone clinics, and irregularly, it depends based on the on-demand. But the second one is bi-weekly counseling, and we have behavioral contract, we have quality assurance using BDRC checklist developed by Dr. Marek Czawarski from Yale, and we have a clinical supervision, and we did the monthly internet-based conference call, Skype, with George and Dave and Marek. We use these instruments, locator form for the methadone users who move several times, so we can track the address. We use ICD-10 checklist. We use addiction severity index with several modification. Risk assessment battery, what's the risky behavior for the methadone users. non-medical service form, and WHO quality of life. So we assess the quality of life of the methadoners. So an adherence and lab form. Also debt cap, so assessing economic value of the counseling. So we try to get the data regarding economic value. So this is our research team, 55 researchers, doctors, nurses, social workers, statisticians, and economists. What we have done so far is training. We did 3 times training for data analysis, data counseling, data collecting, and all the counseling process. Translating instruments, because we are not using English as our mother language, so it's very important to translate from English into Bahasa Indonesia in the first step, and sending JAKPRO system to attend scientific meetings in several events. So this is discussing problems with counselors, training, discuss the obstacles. These are the data from study arms at sites. We have 5 sites. BDRC and treatment as usual. Most of them are males. It's a bit divided by age group. And HIV status prior to baseline. In Indonesia, we still have HIV positive patients among injecting drug users, lots of. So our country is one of the 3 countries still have the HIV positive drug users, besides Ukraine and Russia, I think. So it's our problem, how to not only provide methadone, but also HIV treatment for them. So this also regarding hepatitis C. We also have problem with hepatitis. And urine test completed, we did 1,372 urine tests. So regarding the substances abuse, amphetamine, methamphetamine, cannabis, morphine, and benzodiazepine. Based on my clinical experience, when I asked the patient, why that you prefer not to increase your methadone dose, and why do you use alprazolam, they mentioned that I'd rather to have a lower dose of methadone because I need to get high when I inject, and also I use alprazolam is kind of a booster to boosting my feeling. So once I drink the methadone, and then I followed by the alprazolam. So this that's why the benzodiazepine is also a problem in Jakarta, especially. Substance abuse by sites. So if we divide it into 5 sites, you can see still benzodiazepine is one of the best drug that they use. They love it very much. And this is follow up 6 months after the baseline. We completed 90% of them. Loss of follow-up 21 and death case 7. This follow-up 12, we still have a very good follow-up, 92%. This follow-up rate is very, very high. This is one of the results from the same study, but only look at the psychiatric symptoms and risky behavior. I only used 86 of them. We use basis 24. It's developed by McLean Hospital in Harvard. So 59% of these methadone patients were found to be HIV positive, more likely to be married, but did not differ by HIV status. The others, participants reported being most troubled by difficulty in managing relationship with family members and others, and more trouble in dysfunctional areas. Participants reported moderate rates of use of range of illicit drugs with significantly higher proportion of HIV positive patients, benzodiazepine and marijuana. So these two kind of drugs, the most favorite. Injection risks reported by both HIV positive and negative participants. Needle sharing was common among HIV negative participants. We even have a rental of a used needle. So when I discuss with my patient, some of them said that I rent a used needle. It's not because it's very expensive for getting a sterile equipment, but they just want to have an easy access and then get this the needle rent. Although lower, unacceptable frequent among HIV positive participants. Another study that I conduct 2005. Also, 70% of the HIV positive drug user still sharing their needles in some area of Jakarta. So 70% of them still sharing the needles, even they are HIV positive. It's another survey, and the data that is very difficult to find a new patient right now. Many hypotheses about it in Jakarta, especially because one is many of them already died due to HIV/AIDS and hepatitis C, untreated hepatitis C, and the second is heroin is only for the losers for them. Some of patients mentioned about it. Heroin is only for Mick Jagger and flower generation, not for us, the younger generation. So we prefer to have stimulants, amphetamine type stimulants, and even there are many new drugs in Jakarta right now. We have crocodile already. We already have bath salts, spice, all kind of drugs. Precursors are from China and locally made in Jakarta. So, welcome to the jungle. So, it's a new kind of drugs. All the synthetic drugs are rife and used by the Jakarta residents right now. So, I don't know, is it the reason why it's very hard to find a new heroin patient. This is the spot check urinalysis from other study. Cannabis, methamphetamine, and benzo. Regarding those, it's very hard to convince them that, how to say, getting a higher dose, optimal dose, is better for them. Many of them told me that I don't want to get a higher dose, doc. I prefer to have a lower dose and then I can combine with other drugs, so I can get high. This my reason why. I just want to come to your clinics, getting a methadone, but do not increase the dose. Yeah, 42% under 80 milligrams the dose. So this is another study. It's only 32% above 120 milligrams. So this the challenges that we have while running the study for 4 years. Coordination between Ministry of Health and professional government, because we have 5 sites. One belongs to Ministry of Health, the others belongs to Jakarta provincial government. So it's difficult to collaborate and coordinate. Ethical clearance, we have to get the ethical clearance from both sides, from PAN and also from our Ministry of Health. Building such team is a long time, 4 years, 55 researchers. And lesson learned that from the study, we have to prioritize MET based on local resources. The second one, consider readiness of service providers. Many of them said to me that doc, especially the nurses, I provide the service in the morning for the children and for general patient, and in the afternoon we have to provide Methadone Program for the drug users. It's overburden. So in Jakarta, in one clinic, they have to work from the morning to the afternoon. In the morning for general patient, and the afternoon for the drug users. So because it's embedded into established community health center. So that's the reason why they complain about the overburden, and involve all stakeholders, include law enforcement and drug users. So that's why we have Methadone User Society in our clinics. And regarding sustainability issue, because we still have import the methadone, but we have the pharmacy for distributing them in nationwide. Thank you for your attention.
We have time for some questions.
Could you comment on the traffic and how the traffic situation here relates to access? The traffic railroad, the cars. Your patients have a lot of trouble getting to this.
Yeah, Jakarta is one of the worst place for traffic jam. So worse than Bangkok, worse than Hanoi, worse than any other place in the world. So if the methadone patient have to go to the methadone clinic, it's better to have a clinic nearby rather than have to go to another part of Jakarta. So we have 13 million population. So it's a quite populous city.
American prisons have been very resistant to using methadone except for pregnant women. What's been the level of reception in the prison system in Indonesia? What obstacles have you faced? How did you overcome them? How many people are in treatment?
Yeah, for providing methadone inside the prison, in the beginning is very hard because we have to convince Ministry of Justice that this is good for the drug user inside the prison. Of course, the obstacles are pros and cons. The cons said that they already prisoners. Why they have to be treated with drug user? But the reality, they still inject inside the prison. So our government finally decided that okay, and we have to select several prisons with some of them with the drug users. So we try to provide methadone program inside. Nationwide, we have more than like 35, 40 prisons with methadone programs nationwide. I don't know exactly the data, but I can give it to you once I got the exact number of the methadone program inside the prisons. So it's not only, the obstacle not only from the Ministry of Justice. We are majority Muslim country, even from the ulama, from the religious leader. Why you provide methadone? Why you give a substitution for heroin? It's forbidden in our religion. So, but some of the health provider argue that they will inject anyway. They will use the heroin. So we have to how to say, reduce the risk of getting HIV/AIDS rather than let them die. But I mean, in Indonesia we have two kind of approach: harm reduction approach and drug treatment approach. We have to be very careful in these two sides, because if we lean too much to the harm reduction approach, we can provide everything, but we have to be very careful. We have to be very select, because lots of rejection. But that's why coordination between the health provider, the community leader, and also the drug user itself is very important. Okay.
So, speaking of harm reduction, in some places in the United States there are needle exchange programs for injection drug users. Has that ever been talked about in Indonesia or in Jakarta?
Yeah, but now we have kind of win-win solution, because many of rejection regarding providing the needle changing. For MET, medication assisted treatment, usually the health provider, the hospital, the clinics provide that, methadone, buprenorphine. But for needle exchange, usually the NGO, non-government organization, provide that. We have to be very careful, because these two approach, we have to be balanced and work together to fight against the drug use and HIV/AIDS in this world, actually. Okay. Thank you.
Next we have Matthew Hickman from University of Bristol in England, and he's going to be talking about some of the issues related to mortality in opioid addiction. Dr. Hickman.
Good, and I must thank NIDA for inviting me here. I've got to do my disclosures, but I'm a public health professor. I don't have many disclosures, unlike my clinical colleagues, as you'll see later. I wanted to talk a little, well, primarily I want to talk about opiate substitution treatment, whether it's methadone or buprenorphine, and the risk of mortality in the population. So the risk of mortality during treatment and after treatment. And mortality is one of the most important public health problems of opiate use. An overdose, usually in most cohort studies, is one of the commonest causes of poisoning. Well, overdose is a commonest cause of poisoning in many countries, more than people who die from paracetamol or antidepressants. And their risk of death for people who inject drugs can be over 1% per year, although we just saw for Jakarta it's even higher than that, although it might not just be overdose. And if you compare this to the general population, usually people who inject drugs have a risk of death that's over 10 times higher than the general population. And in some studies suggest that over 10% of premature mortality in young people, 15 to 34-year-olds, is due to opiate use. But first I want to talk about hepatitis C and HIV before I get on to the bad news of mortality. Now, several systematic reviews have suggested that there's insufficient evidence of an effect of opiate substitution treatment on hepatitis C. So we're now updating the systematic reviews, but in lieu of that, we pooled some data from studies in the UK which measured exposure to opiate substitution treatment or high coverage needle exchange, and also the risk or the incidence of hepatitis C. And if I can get my pointer to work. Yeah. So from opiate substitution treatment, we can see that the risk, while people are on opiate substitution treatment, the risk of hepatitis C is reduced by, by 60%. And if you're on opiate substitution treatment and high coverage needle exchange, the risk of hepatitis C is reduced by over 80%. We did the same, published recently for HIV, and again, HIV, in the literature, mostly there's been narrative reviews suggesting that, yes, opiate substitution treatment reduces infection risk, but very little quantified data. So we did this recently in the BMJ, pooling trials and observational studies, and suggesting that if you're on methadone, mostly it's methadone, your risk of HIV is reduced by over half. And that's probably an underestimate, because the trouble with observational studies is they tend to pick up people who are still using, still injecting. So trials are better because they can pick up people who, while on treatment, are no longer using. But of course, you can't do a trial anymore of opiate substitution treatment on HIV. So we think this is a minimum estimate. Now, we also looked at studies which compared people who were exposed to detoxification or very short-term therapies versus no treatment or versus methadone, maintenance. And what this suggests is that detoxification, actually, there was no evidence that detoxification had a positive impact on HIV. If anything, it was the reverse, that HIV risk was increased, probably because of the high rates of relapse. Now, this is a very small study, and this was a sub-analysis, so it's only a hypothesis, but it's something that needs to be looked at in more detail, and also is a bit of a sign, which is what we're interested in elsewhere, in that if you're giving short-term therapies and you've got high rates of relapse, then the public health benefits may be worse than giving no therapy whatsoever. So, I'll talk about mortality, and I'll talk about 2 UK studies, which I guess, because I'm in America, is international, and then an Italian and an Australian study. And the first cohort is one in a very small place, in a single medical practice in Edinburgh, collected by Roy Robertson, who's a GP. And it was an open cohort. Now, it's a Muirhouse Medical Group is basically it's in a public housing scheme. It's in the middle of it, and it has a sort of population of about 10,000 people. He established an open cohort of patients from 1980 to 2006 of nearly 800 injecting drug users, and we followed them up from 2007 to 2009. Now, 28% of them were dead before we followed them up, but we had their medical notes, and we managed to find and interview over 3/4 of those that were still living, and went through over 80% of all cases through their primary care records or through interview. The first analysis I want to describe to you is about looking at the relationship between opiate substitution treatment and long-term cessation or survival or death. And this is what we call a competing risk, because what we're interested in is what's the effect of treatment once you start injecting on whether you die before you achieve long-term cessation or hopefully you achieve long-term cessation before death. Now, obviously, this is quite an easy variable to measure. It's 0 or 1. But long-term cessation, I mean, you'll know better than I do. If you look at the literature, there is no real, well, what's the definition? How someone achieves this long-term cessation? So we looked at the various long-term cohorts that had tried to establish it, and we came up with this definition that you've had to have had at least 5 years reported of no injecting, and that was our outcome. And in our data and several other cohorts, such as cohorts in California, if you've got more than 5 years, your likelihood of relapse is pretty low. It's less than 10%. Okay, so I'm going to show you 2 figures and then a bunch of hazard ratios, which I'm obliged to do as an epidemiologist. And so this is from survival, and it's from time of injecting to, well, this is to any time before achieving long-term cessation. And it shows a dose-response relationship with time on opiate substitution treatment. So the blue line are people who never go on to opiate substitution treatment, and they have the poorer survival rates. Each year on opiate substitution treatment, your survival is improved. Now this shows a contrary relationship. Now this is time to long-term cessation. So there's a large group of people who give up in the first year of injecting. So some of these might not even have developed very severe dependence. Others will have given up. But the blue line here, this time, is of those who are not exposed to opiate substitution treatment. Now, these lines are converging, which we test statistically, but there doesn't seem to be a positive relationship between going on opiate substitution treatment and time to long-term cessation. If I show you the hazards, so these are like risk ratios or odds ratios, which, and so this is and it's a competing risk, so you compare the two. So the time before achieving long-term cessation, if your hazard is less than 1, you've got better survival. And over here, this is time to long-term cessation. If your hazard is less than 1, you've got a longer time of duration of injecting. So what we want over here is less than 1. We also want it over here as less than 1. So this is just showing the figures. Opiate substitution treatment improves survival, but is not really associated with long-term cessation. It's not a given thing that if you improve survival, you then give people an opportunity to continue injecting, because, or the vice versa, because if prison history is associated with worse survival, higher risk of mortality, and also prison history is probably confound for many other things, is associated with a longer duration of injecting as well. Whereas a history of heroin overdose, unsurprisingly, is associated with poor survival, with a higher risk of death, but is unassociated with long-term cessation. And in this cohort, where there was an epidemic of HIV in the early 1980s, it was a sort of epicenter of HIV in the UK, actually, and it was written about in the film Trainspotting, in which it said never inject with someone from your house, for obvious reasons. The HIV infection is strongly associated with poor survival because it's the time before antiretrovirals, but also HIV was associated with a shorter duration of injecting. Okay, so that's for time from starting and long-term cessation. Now I want to look at transitions, because as we know, opiate use is a chronic relapsing problem. So we want to look at some of our transitions for 405 surviving injectors. And we did this because, unfortunately, the data we had on those that had ceased before follow-up that we could get from medical records didn't really give us reliable data, sadly. But the median number of transitions was 3 between on, off, or relapse and recovery. Mean was 5, and the range from 0. So there were less than 5% of the population had just continued injecting, no transition whatsoever. And then one person had 81, or reported 81. They also had about 40 periods imprisonment as well, so they were just going in and out, in and out, but yeah. And as you said, in the first year, there was still a substantial proportion who injected for less than a year, recovered, no relapse whatsoever. And then we had quite a few people who had at least one cessation period. So I'm going to show two figures, and this time, this figure is from time to first cessation, from when you start injecting, when the cohort started injecting. So the median time to first cessation was 1.5 years. And the probability that someone had achieved some form of cessation within 5 years was nearly 3/4. And what's slight interesting thing about this is this occurs very early on in an injector's career, whereas often cohorts are picking people up at age 30, but actually a lot of interesting thinking happens at age 20 or below. So that's time to first cessation. Time to first relapse is shown here, where this is quite an interesting. There are a bunch of people who, after their first cessation, do not relapse. The median time in our cohort was 2.25 years, or 2.4 years rather, and the probability that relapse occurred after the cessation within a year was over 1/3. So again, you've got, as you know, this pattern of people coming in and out. So what we wanted to look then is, well, okay, what's the impact of opiate substitution treatment on these transitions? Transition to cessation and transition to relapse. And there's another bunch of hazards. So here, our hazard ratio for cessation, if it's less than 1, or rather, if it's greater than 1, it means you've got a shorter time to cessation. You're more likely to cease. And here, time to relapse is if your hazard is below 1, you're less likely to relapse. If it's above 1, you're more likely to relapse. And so what we find is a very strong association with exposure to opiate substitution treatment to cessation. So, which is good news, but probably unsurprising. But, opiate substitution treatment, you do cease injecting drug use. But there was very weak evidence. In fact, if my statistician says I shouldn't even say the word weak, I should say insufficient. There's insufficient evidence of an association between opiate substitution treatment and relapse, or prevention of relapse. In other words, they relapse at the same rates as anybody else. There was an association for relapse for women. Women were less likely to relapse than men, which may be one suggestion of why there are differences in the duration of injecting between men and women. And there was a relationship between age and probability of relapse. So as our cohort aged, they were more likely to recover. They were less likely to relapse as they aged. There was also a relationship with the number of previous cessation periods and the next cessation. So there was a shorter time between time to the next cessation as people had previous cessation. So as they aged, they were more likely to recover, and as they had had 1 or 2, 3 periods of cessation, they were more likely to try again. So this is a bit like tobacco as well. So what these study adds in terms of the two studies was opiate substitution treatment. And this, I forgot to say, this is delivered in primary care, not in specialist drug clinics. I mean, it does improve long-term survival. We know that it improves short-term survival, but key is here long-term survival. And there's a dose-response relationship. But it might not be associated with an increased chance of injectors will, it may not hasten long-term cessation. But opiate substitution does increase that time to the next cessation period. Women have a reduced risk of relapse. Relapse decreases with age, and also the time to next cessation reduces with each subsequent injecting period. And there's an indicator of some maturation. There's a sort of old literature about whether injecting is like criminology careers that people mature out of. And this relationship with age and with number of cessation periods suggests that there is a maturation period. But what's critical is that this is within a population heavily exposed to opiate substitution treatment. So now I'm going to look at another cohort, and I'm looking, I've lost my watch. I have no idea what the time is. Okay. I have to be dragged off. Okay. Good. Right. So now I'm going to look at instead of going for this from one small housing estate in one small city in the UK, now I want to go across the UK and an analysis of the general practice research database, which is about 5% of all the people in the UK, which is about 55, 60 million. Data is extracted from their records. And we looked at people on methadone or buprenorphine, and there were between 1990 and 2005. And there were just over 5,500 patients on opiate substitution treatment. In the UK, there are some GPs, despite guidance against it, who like to use dihydrocodeine as a substitution treatment, so we added that in as well. All the patients had these drugs given as substitution treatment, and then we did ensure that they had a diagnosis of substance abuse. And there were about over 250,000 prescriptions, and just over half were for methadone-only patients, only for methadone. Oops. We defined, and this is a secondary analysis of routine data, so we had to define, and unfortunately, however much you pay GPs, they don't always record completely good data. So there were some missing observations, missing dosage, missing times when we couldn't tell whether they were on therapy or not. And so we defined on treatment as anywhere where there was a gap of less than 28 days between prescriptions, because it was quite unlikely for you to leave treatment and then be able to persuade your GP to put you back on treatment within a month. But anything after 28 days we considered probably was a new treatment episode. And so there were about 13,500 treatment episodes. The mean, this has become important a bit later, the mean was 8 months on opiate substitution treatment. Over a third had therapies of over 12 months. And in terms of person years follow-up, we stopped following the people up in the records after 1 year after their last treatment episode. And so we accumulated about nearly 9,000 person years of people on opiate substitution treatment, and a similar when they were off opiate substitution treatment. The overall crude mortality rate, the annual, was 1%. 0.7% or 0.7 per 100 person years, if you like, on treatment, and 1.3 off treatment. So once you adjust for differences in age, sex, and comorbidity, being off treatment has a risk of death twice as high as being on treatment. So treatment is protective. And there are also differences between men and women in the UK. This isn't true across all international cohorts. But in the UK, men have a rate of death twice as high as women. So now I'm going to look at the risk of death in different periods while you're on opiate substitution treatment and while you're off opiate substitution treatment. So the baseline period is the remainder of time on treatment. That's after 4 weeks. And I'm really sorry, I should have improved these a bit. So here, the risk of death was about 0.6% per year. And so it's got an adjusted mortality ratio of 1, and we're comparing that to the rate of death in your first 4 weeks on opiate substitution treatment and the rate of death in the first 4 weeks after you leave opiate substitution treatment. So compared to this, when you're settled on opiate substitution treatment, your risk of death in the first 4 weeks is 2 to 3-fold higher. There's this, well, whether it's an elevated risk of death at the beginning of treatment or actually it's the same risk of death if you've got outside of treatment is a discussion we can have later. But critically, once you leave opiate substitution treatment, and when you say leave, that's either that you've managed to get them off or the patient's just skipped off. The risk of death in that first month is 8 to 9 times higher. Massive elevated risk of death in that first month leaving treatment than when they were on treatment. And if you look at the relationship between the risk of death in the first 4 weeks after treatment and the risk of death the remainder of time off treatment, is about 4-fold difference. And this is quite interesting because this is the same relationship we find when people leave prison. So when people leave prison who are opiate users, heroin injectors, their risk of death in the first month of leaving prison is 4 times higher than it is the rest thereafter. And it's because of the same process of opiate-naive patients, high rates of relapse. Now, if we turn these odds ratios, or actually they're Poisson, so it's a rate ratio, and we turn the baseline now into the rest of time off treatment. And so we consider that the baseline, and we assume that the rest of time, this stands for what the risk of death is if they were never in treatment. And then we look at the different periods of when they were on treatment, but in the first 28 days, rest of time on treatment, and then the first 4 weeks off treatment. And then we can work out, well, okay, in the population, what's the relationship, how likely is that treatment is going to lead to a reduction in opiate deaths, given different averages duration of treatment. So here, and we've done a ratio here, so we've estimated estimated the probability of death if you're on treatment or if you're off treatment, and then calculated a ratio. So if there's no difference, the ratio is 1. So at 1, there's as many deaths in the population as being on treatment or off treatment. If it's above 1, there are more deaths due to treatment than there are being off treatment. And we want it to be below 1 because we want treatment to have a protective effect in the population. And so the horizontal axis is the average duration of treatment. And so as you can see, it's only once you start to get an average duration of treatment, that's from our cohort, of above a year, do you start to see that there's a protective effect of treatment on opiate overdose deaths in the population. So what I showed you before is that the average duration was about 8 months in the UK. And so the hypothesis is that actually that might be too short to have an impact on driving down the number of opiate overdose deaths in the population. And we can derive this sort of probability curve of saying, well, what's the probability that treatment will reduce the number of deaths in the population given average duration? And it gets above 85% probability that you're making a difference in the population once you get to treatment durations of over a year or over. Okay, so what this study is showing, again, we were showing a 2-fold difference in risk of death between men and women. I haven't showed you, but there was no strong evidence in our cohort of an effect of OST dosage or planned cessation, but that's probably because we were looking at primary care data, not specialist drug clinics. And as I told you, there was this interesting 4-fold difference between the risk of death in the first month and the rest of time and off treatment, similar to prison release. But what this raises is this hypothesis that opiate substitution treatment's impact on drug-related mortality relates to the duration of treatment. And so that's what we should be looking at in terms of how we can drive down the number of deaths in the population. And in the UK, which maybe John will show later, we've had a 5-fold increase in the amount of methadone prescribed, but have yet to have a substantial impact on the number of overdose deaths in the population. Right, have I got time to drift to Italy? Okay. So now I want to talk about Cohort in Italy. And I can't remember what VEDET stands for, but it's in Italian. And it's a national multi-center longitudinal study. And this was 1 in 4 statutory clinics in Italy. And they recruited about nearly 10,500 subjects enrolled between 1998 and 2000. And they followed them up until the end of 2000. And this is a classic thing, is they spent all their money on recruiting patients, and then they ran out of follow-up time. And the median days of follow-up was a year and a half, and we had 10,000 person years in treatment, which is great, but only nearly 3,000 years out of treatment. And similar to other cohorts in the UK and also in the States, where mostly men and mean age was 31, and most of them were injecting drug users. And we looked this time at overdose deaths in and out of treatment. And the other interesting thing about the vedette cohort was that it looked not just at opiate substitution treatment, but also methadone maintenance, therapeutic communities, detoxification, other pharmacological and also psychosocial, where it was delivered not as part of pharmacotherapy, so psychosocial alone. Right, so the strict comparison of just the risk of death in treatment versus out treatment, we had a hazard ratio in the UK of, well, if I reverse it, of half. So treatment halved the risk of death. In this Italian cohort, it was a hazard ratio of 0.09. That means it's 10 times lower. The risk of death is 10 times lower in treatment in Italy of overdose than it was out of treatment. The risk of death out of treatment, annoyingly it's per 1,000, is the same, 1%. But in treatment, much lower. And what's interesting is that we also had a very strong protective effect across all of the treatments. We were slightly underpowered, but it meant, it wasn't just pharmacotherapy that reduced the risk of death, other therapies did as well. And when we reverse those hazard ratios, we can see, yes, comparing people in treatment as our baseline and comparing it to out of treatment, there was an 11-fold difference. And if we look in the first 30 days since last treatment, the difference again was elevated. And it's this time, instead of being 10 times, which we found in the UK, it's now over 25 times higher risk of death in the first month leaving treatment in Italy than when the risk of overdose during treatment. And this relationship between the first 30 days and the rest was again about fourfold. So similar, there being this elevated risk of death in the first month leaving treatment. Now that was a cohort study. We also wanted to replicate it. We did a nested case control study because we wanted a bit more follow-up because we were a bit worried. And we did that in Piedmont, which is Turin. Lazio is Rome. And here we had nearly 4,700 heroin users, and we followed them up for a much longer period, and we had 127 overdose deaths. And we did a sort of density case control study, which means every time someone died, we then took 4 controls at that time, and that meant that the risk ratios you get are the same as a cohort study. And the risk of death was still substantially reduced during treatment, but here the odds ratio, instead of being 0.1, was 0.2, but still, so that's a five-fold difference in the risk of death during treatment compared to out of treatment, and still substantially lower than the risk of death in the UK, as we'll see in Australia as well. Again, all treatments were protective, and we also showed the risk of death was elevated in the period after treatment, where we had a 30-fold odds ratio if they'd recently left. If they were left treatment in the last 30 days, their risk of death was 30 times higher than elsewhere. And Fabrizio Feggiano, I'm going to give you his email, and you can write to him, because I presented this 2 years ago in Philadelphia and said, we will be publishing it soon. And you've all got to email him and say, can you please publish this paper now? Okay, so moving to, have I got time to do Australia? New South Wales, so this is a cohort of people prescribed methadone from their methadone register, also buprenorphine register from 1985. And New South Wales is Sydney. And they had 42,000 patients, just over 400,000 person years exposure, and they had about 2.5 treatment episodes per person. And their mortality rate, 1%. Same as we saw in the UK, same as we saw in Italy, the general mortality rate. And I'll just show you one, I think I'm showing you one table. So this shows the rate ratios, that's the risk of death by different treatment periods. And here the reference period is the period out of treatment, where the risk of death is about just over 1% here. So the in-treatment period, like the UK, half-fold difference. So during treatment, you reduce the risk of death by half. But interestingly, in Australia, in the first 2 weeks, they have a much higher risk of death. So they have a very elevated risk of death at treatment initiation compared to the rest of the time. And actually, they have a higher risk of death in the first 4 weeks of treatment than they do out of treatment, in the first 4 weeks of out of treatment. Okay. So what these additional cohort studies add is, again, we show that that treatment is protective. It reduces the risk of mortality. Non-pharmacological treatments can do that as well. But there is this massive risk of death after treatment when people leave treatment because of high rates of relapse. Now, in Italy, we see much larger differences between the risk of death during treatment and out of treatment. And in Australia, we see much higher risks of death. You could say, what is Australia doing so wrong when they initiate people on treatment? They also might say, what are we doing so right when they leave treatment? But there is a suggestion, and I put this as a joke, but what is the Italian effect or Mediterranean effect? It's not obviously cardiovascular disease and olive oil, but there might be something else going on in the way treatment is being delivered in Italy, or the characteristics of those patients, which means that while they're on treatment, their risk of death is much lower. So I won't. Yeah. So I got 2 slides to end, if that's okay. What I wanted to now, these are largely treatment cohort studies trying to look at the risk of death during and after. And it's important, a real problem in this kind of study is power, because if you go to the literature and you say, I want to look at randomized controlled trials that tell me whether methadone and buprenorphine reduces the risk of death, you won't see anything in the literature because the trials are all too small. They're underpowered. They can't really tell you. They tell you about other outcomes. So when you want to look at death, you have to look at observational studies, and you have to look at very large observational cohorts and studies. So in the UK, we estimated that about 1 in 300 treatments will, when 1 in 300 people, when they leave treatment, will die in that first 4 weeks. But there are very few clinics that will have sufficient numbers of patients that they're seeing that they would even notice this occurring. And if we wanted to evaluate a new way of delivering opiate substitution treatment, which said, well, we will reduce this risk of death in the first 4 weeks leaving treatment by half, let's say that's what we want to measure. We need 30,000 patients to be in our data set. So you ain't going to get a randomized controlled trial to do that, even in the US, where you've got lots more money than we have in the UK. I won't go into the methodological differences. You can tell me about those later. And I must, which is true of all observational studies. I mean, we've just recently got funded to redo the analyses in the General Practice Research Database, and we'll have a bit more power, and we'll be able to look at differences between buprenorphine and methadone, which we couldn't look in other studies. But what I think is really exciting is the idea to explore multi-center, multi-country cohorts, observational cohorts, but where we can try and compare what's the risk of death during and after treatment, but also try and categorize, well, what are the similarities in our patients' characteristics that might be related to the risk of death or that might be protective, and also characterize better the way treatment is delivered so that we might be able to identify, well, which way treatment is delivered may be most better for treatment or for reducing the risk of death. I mean, I'm an epidemiologist, and it strikes me that, that if you don't know if someone's going to relapse, you keep them in treatment for at least 12 months. Well, that's what these data are saying. But there might be other, I'm sure there are greater detail that can be brought into bear. Thank you very much.
Of the treatment in Britain in the primary care offices, was this primarily Suboxone or was this
The large UK primary care, it's half of it is methadone, and maybe 30–40% of it is buprenorphine. We don't really do much Suboxone. I mean, it is there, but it'll be sold buprenorphine. And 10% is dihydrocodeine.
Mm-hmm. And do you make any attempt, or have you seen any figures elsewhere on crime rates associated with replacement therapy?
Say that again. With what? With
crime rates. The French claimed that there was significant reduction in crime with the introduction of Suboxone. Do you see anything like that in England?
Well, yes, and we've got studies that show that if you're on treatment, your reported crime has gone down. Reported crime in the UK has gone down. I mean, one of the theories that the Home Office are now trying to promulgate is that that's because we've got an aging cohort of injectors. So it's due to treatment, but also due to actually characteristics of the cohort. But I don't think there's no data to show that Suboxone is better than methadone on reducing crime. Treatment reduces crime.
Thanks.
Okay.
Our final speaker is John Strang from King's College in London. And Dr. Strang is going to talk about two potential interventions, one a much larger administrative intervention, and then the second one providing rescue naloxone to try and prevent some of these deaths that we just heard about. And then we'll have some, discussion.
So I'm doing two shorter talks on topics of interest where there's a question that, in our view, is capable of answering, so it's worth doing the research to try to get that better answer. First one follows on very logically from Matt Hickman's presentation. We have a particular problem in the UK of methadone overdose deaths, and the questions to be asked are to what extent are new guidelines that we might introduce at a national level, do they make any difference? And then secondly, our introduction of more widespread supervised dosing, has that actually made any difference? So as Matt said, I've got a longer list of declarations than he's got, but just to guide you through them, it basically means I've worked with government departments in the UK and internationally. I'm also a clinician, so there are service providers in both the NHS and third sector organisations. I've worked with various pharmaceutical industry, also policy review groups and charities. So two questions. Do guidelines make any difference? Many of us in this room might have sat on guidelines committees, and you waste cumulatively many hours of your time on these committees, and it's sobering to think, does it actually make any difference? So we'll look at that first of all. And then if changes in clinical practice occur, does that actually then make any difference to lives saved? It's the second half. So various acknowledgements to colleagues who've worked with me on different bits of the work. Just a quote, we did a book years ago about methadone matters, and the point we've got to bear in mind is that methadone is a powerful opiate drug. There's no question that methadone can be curative and healing in the work that it does, but also if it's handled badly, you kill your patient, which is clearly not a good thing to do. And the challenge is how to achieve the former without incurring the latter. So one of the anchor points to this presentation is we had a significant, we have a document called the Orange Guidelines, which is a sort of workshop manual for how you should be doing maintenance treatment or methadone treatment. And this came out as a significant bit of policy advice. And so let's look at, did this actually shift clinical practice at all? If you're wanting to read it up in more detail, I'm just taking bits from the paper that we published, looking at whether guidelines make a difference. And the key bit to doing this this analysis was we looked at the guidelines for recommendations that were measurable, and we wanted to see if you make a recommendation and it's one where you can measure change of practice, then how much does that practice change? We identified 7 different areas of practice where we reckoned we could measure the extent to which change then occurred. And the ones I'm going to concentrate on, firstly, in the UK, we have a much more varied prescribing practice, much more varied or anarchic prescribing practice. So we had things like methadone tablets and methadone ampules being prescribed, and there was recommendations that these should either not be prescribed or only in special circumstances. So there's something clearly measurable. You measure how much it's being done beforehand, you make a significant policy and practice recommendation, you measure how much it's happening subsequently. We had virtually no supervised dosing of methadone at that time, back in the 90s, 80s and 90s. We made an explicit recommendation that there should be a much wider use of supervised dosing and daily dispensing, and that again is measurable. And then finally, we were concerned that so much of the dose of methadone being prescribed was below recommended levels, so we made recommendations about doses. We had already done a survey of medical practice in the mid-90s, and we repeated that in 2005. So we were able to look at to what extent have practitioners and the way they actually deliver practice, how much has that changed? So from the point of view of, I said we had both tablets and ampules being prescribed. You can see back in the mid-90s, we had about 20% of the methadone being prescribed was in other than the recommended oral mixture form. And you see a reassuring, substantial change of medical practice. Whatever it feels like when you're trying to talk to doctors and getting them to change their practice, it looks like we do gradually over time. So that's quite a significant change, with both of those becoming much rarer activities. You then get on to sort of slight changes which are still there but not so impressive. We were concerned about the amount of unsupervised move to take what in US terms would be take-home doses from the outset. We see an increase in the amount of daily dispensing, but still only modest. So from this point of view, medical practice hadn't changed much over a period of a decade. And when we look at the dose data, so looking at mean daily dose, we were seriously concerned at the time of the guidelines that mean dose was 47 milligrams. That had increased moderately over the intervening years, but that's still a considerable cause for concern. So let's look at this. Let's look at this graph about the daily doses being prescribed. So, did the point? Oh, yeah, it is. Yeah. So what doses are being prescribed? Well, most of the doses being prescribed are in the sort of 40 to 50 milligrams. What doses were we recommending? Well, we'd had 2 different reviews and recommendations. One had recommended it should be 50 to 100. Another had recommended it should be 60 to 120. Whichever one we're considering were a long way adrift from what recommended practice is. So this is before the recommendations. And then 10 years on, after there'd been not only the guidelines but active promotion of this, we see that the curve has shifted across to the right. We have more prescribing going on. There's been a big increase in the number of patients in treatment, and the curve has shifted to the right. But we still have a large amount of practice below the bottom end of the recommended dose range. So if we look at it from that point of view, if we take that recommended dose range of 60 to 120, which quite a lot of attention was given to, we previously had only a quarter of practice was in that range. That's improved up to 40%, but it's also back to that thing of, do you think, do you think the bottle is half empty or half full? That's still pretty sobering. You've got 60% that is outside the recommended dose range. And we didn't have the original data for buprenorphine because it was not licensed in the UK back in the early 90s. But it looks pretty similar, that you've got the same situation with a large amount of dosing. So regardless about what is the correct dosing, how far do doctors comply with the advice and direction that they're given? Okay, so does anything change? Yes, it does change. There's a moderately optimistic conclusion that doctors change in the direction that they're steered in, but it's not overnight, and it's not as much of a change as you'd want. So we then, working with Matt and colleagues Sheila Bird and Wayne Hall, we then wanted to test the extent to which not only might doctors have changed their practice, but might that be translated into sort of less drug-related deaths, for example. We were particularly interested in the amount of methadone overdose deaths that we had in the UK being reported at post-mortems and such. And we were introducing supervised dosing, and our hypothesis, articulated actually at the time, but not as a research hypothesis, was that we were predicting that this expenditure was warranted because it would reduce deaths. And then both as researchers and with a bit of nervousness, we then thought we'd look back over whether all that effort had actually made any difference to methadone deaths. And we realized that we would have to correct for the baseline about the amount of prescribing. The amount of number of people in treatment was going up. So we would need to look at the number of methadone deaths that were occurring for each million doses of methadone being given out. So it's a measure in some ways of the safety of the delivery of the treatment. Right, now this is an absolutely horrific graph, so you're welcome to go to the paper and look at it, but let me just sort of guide you through it. What you have along the top is Scotland. In fact, it's like the geography of the island. So you have Scotland at the top, and then England being a bit bigger as a box below. I hope there's no Scots that I'm causing huge offence to by this comparison. This is a timeline from the early 90s up to the present time, just about, of when did supervised dosing come in. So this is like a big, big natural experiment. You have both Scotland and England without supervised dosing. So it's take-home doses from day one. And we're introducing a safety measure. And it's introduced in Scotland first, in the mid-90s, and then it's introduced sort of less efficiently and more slowly in England a few years later. And we realized we've got an opportunity here. We can look at where the methadone deaths go down, and not only do we look if they go down, but we'd expect the shape of the change to match the different timings of those changes in both policy and practice. So what do we see? So this is measuring the number of deaths per million doses dispensed. And what we see, sort of extraordinarily occurring just around the time of the introduction of supervised dosing, is that the deaths per million doses drop down to a quarter of those levels over the course of a few years. And in England, it occurs a bit later, and it occurs more slowly and gradually. So it seems to us not only has methadone treatment become a great deal safer as a result of these changes, but also that it appears to match almost exactly the observed time course of these changes occurring. By our calculations, as a result of those changes, we did approximately 2,500 methadone overdose deaths have been prevented. So just concluding this section, firstly, what about guidelines as a way of changing our sort of collective clinical practice and policy. Yes, it does work. It's worth doing. But don't hold your breath for the changes to occur. It tends to be a gradual change over time, and it's nothing like as much as we would hope the change to occur. And secondly, in a more of a top-down approach, a centrally driven policy directive appears capable of making bigger changes quicker and translating into actual reduction of methadone-associated deaths. So thank you very much. So shall I go straight on? Okay. So, yeah, so I feel I should sort of take my jacket off and stick another jacket on now. Right, so now moving into a completely different talk, assuming I can master the technology of why is it that other people's scratch pads and mice seem so different from the one you use yourself? Anyway, let's see. Oh, yeah, okay. Okay, so I want to change topic and to look at a different aspect of drug-related deaths. I mean, it picks up some of the points from what Matt Hickman described to you earlier to do with where we seem to see drug-related deaths, but it introduces a different way in which we might be able to deal with it. It's the same list of declarations, so once you've learnt it from the previous talk, you can see it again here. But I've additionally added here, this includes trying to work with the pharmaceutical industry to encourage them to look at better ways of having naloxone. With all due respect to the pharmaceutical industry, it's not a very interesting discussion. It's not a very easy discussion you have. When you say to them, I think you should invest a lot of money in developing a better naloxone, and they say, so this drug is very cheap, how often are you going to give it? And you go, well, hopefully never and maybe once. It's actually quite a difficult conversation to have. But anyway. People ask me all sorts of medical legal questions, and give me a break. I'm a doctor, I'm not a lawyer. If you want some complicated legal bit of advice, then get your wallet and your checkbook out and go and get a proper bit of legal advice. I'm just telling it to you how I see it as a clinician's standpoint. And I'm also particularly paying attention to the idea of what could one do to tackle and prevent deaths from my capacity in a doctor-patient relationship. People sometimes ask me, shouldn't this be available in, shopping malls and things like that? And the answer is, I don't know. I'm working in this sort of paradigm. Okay, why do I think this is such an important issue? And part of the answer is that overdose is the major cause of death amongst drug users, and it is particularly an opiate thing. Also, that most heroin overdoses are witnessed, and that most of those witnesses get stuck in and intervene actively. And anyone who's seen Pulp Fiction, and I presume that's everybody, and if not, you should get up now, go outside and watch it rather than staying in a session like this. But everybody knows how actively people get involved in trying to manage an overdose. And also it includes family members who witness overdoses and are there stuck. They don't know what to do because we never told them how they should deal with that crisis situation. Okay, so what's the problem? Well, why is there a particular problem? Well, let's just do some simple bit of testing. Let's just stick a pulse oximeter on somebody's finger whilst they're injecting an opiate. What happens? I hope you can see the colors. What you've got here is just tracking somebody's oxygen saturation levels in their blood after an intramuscular heroin dose or an intravenous heroin dose. And what do we see? We see a massive difference. With the intravenous dose, over the course of about 5 to 10 minutes, your blood is not carrying the same amount of oxygen to your brain or anywhere else. essentially it turns off your respiratory drive and you aren't breathing. And when you think about it, this is pretty profound, because this isn't just how quickly you've stopped breathing. This is translating it into your venous blood, into your peripheral blood. Slightly sort of morbidly, I actually, for sort of personal health reasons, I was hooked up to one of these things a year or two ago, and it brings out the psychopath in you. You're sitting there in a hospital bed with nothing to do except look at this screen with this clip on your finger. And we were already doing this work, and I thought, let's sort of play around with this. So I thought, let's imagine I've had a heroin overdose, and let's see how far I can drive my pulse oximeter down. I couldn't get anywhere near here. I mean, I could sort of begin to get it to get down to 94, 95, and my brain is just firing away, saying, breathe, breathe. So the notion that that feedback loop is turned off, and you suddenly start thinking, so that's why overdose deaths are associated with opiates. You've turned off the speaker that's giving you that signal. And here's one of the guys that we were measuring after an intravenous heroin dose, and you see he's way below this danger line. And I guess a heroin overdose death, which fortunately we haven't recorded, because it's sort of bad for business, would be just that goes down a bit further and doesn't come back up. Now, the other data, these are data from the UK, just looking at the prevalence of use and where the deaths occur. Because I have colleagues who say, why do you go on about opiates and heroin? Don't you realize there's other trendier drugs, crocodile, all the, and you go, well, there's something pretty nasty about heroin and the opiates when you're looking at overdose deaths. If you looked at the prevalence data of what people are using in the UK, you'd go, John, what are you going on about? This is so small as to be irrelevant. And then if you stick alongside that, where do the deaths occur? You go, wow, that minute amount of heroin use or other opiate use is accounting disproportionately, largely, for the deaths that occur. So it's heroin or it's opiates, particularly when they're mixed with sedative drugs. Now, the other startling thing is how common this is, I'd already been a clinician working in the field for quite a while when I started getting interested in this overdose area, and I didn't think overdose events were that frequent. And of course, you realize there's something about the etiquette of the doctor-patient relationship. Patients are decent folk; they don't want to upset their clinician, and it's a bit offensive to come in and say, I had an overdose event at the weekend. So I guess, whatever reason, I wasn't picking it up, and nor was anybody else. Once we started asking about it specifically, this was the first study we did about it. Was it the first? Oh, no, it wasn't. Anyway, one of the studies we did about it, we find you've got at least 40% from different studies. It's 40 to 50% have already had an overdose. And what was then also striking is a higher percentage have witnessed an overdose. In fact, I think the next slide... and I was also shocked to discover that about 1 in 8 of the people I was seeing had actually witnessed a heroin overdose death. And that really brought me up with a jolt. If I had any idea what they should have done about it, I was speaking, in any single clinic, I was speaking to somebody who'd been there at a time that they could have made a difference. So you then start thinking, well, what should they have known? What could they have done? You're having different countries that we've looked at in all over the world now, a huge number of people having witnessed overdose events. And I haven't bothered including it here, but we've also studied what did people actually do. And there's a huge, the Pulp Fiction portrayal is reasonably accurate. People are terrified by what's happened, but they get stuck in and are active, and they often do things that are disastrous and make it worse. But there is a huge willingness to intervene, and we perversely don't tell them what to do. So you start thinking they're an intervention workforce, and we aren't telling them the correct responses. So it's a common hazard, and it's frequently witnessed. Now, it's even more interesting than that, and Matt's work sort of sheds light on some of this area as well, and he covered it already. So when does it occur? Not only are opiate users, heroin users, a group who are at particular risk, but there are times when that risk is even greater. So post-detox or post-rehab, also during the early phases of methadone treatment, but the one that's an absolute huge one is on release from prison. Now, the prison population, I don't need to tell an audience like this, the prison population is of huge interest to us because regardless of the rights or wrongs or the wisdom or otherwise of choosing to incarcerate this population, what actually happens is there's a concentration of people with this behaviour in the prison population. So if you take the behaviour that I was saying was less than 1% of the general population in the UK, once you go into a prison environment, so the red and the orange bands are the people with an opiate use history, the orange are heroin only, and the red are heroin and other stimulants. But you've got something between a quarter and a third of the prison population having history of heroin use, and so at high risk, they're the target population for worrying about what's going to come to them when they come out of prison. And there was a study, been a number of studies from the UK, both from Sheila Bird and also from Michael Farrell and John Marsden, who worked with me. And they took the large numbers of people coming out of prison with a previous heroin history and looked at the mortality data of those people in the year after they came out of prison. You can, for the full paper, it's in the previous slide. But I just want you to take to this slide. And for some reason, I don't understand. This slide isn't in the paper. Seems to me it's the single most important slide from the whole report. But such, you got to negotiate, I guess, when you try to get your paper published. And obviously the editor didn't like the colours or something like that. I don't know. But I think this is the most interesting study. So not only is there this excess mortality, which is described, but look where it occurs. So let's look at the right-hand side of the curve here, and let's ignore this bit in the orange for the moment. So what you've got here is there an excess mortality amongst this cohort? So yeah, there's an excess mortality anyway. This cohort are more likely to die in that following year than their age-matched norms, but only by a bit. And so the blue bit is their mortality for other reasons, and the purple is the bit that's a drug-related mortality. So their drug-related deaths more than double their likely mortality. But the bit that is absolutely horrific is this first month of treatment, in particular the first fortnight, first month after coming out of prison, and in particular the first fortnight. That first week is an absolute car crash of deaths. And applying these sums to this population coming out, 1 in 200 of them is going to be dead in a fortnight. And you think that is a public health scandal around the world that collectively we've got a responsibility to try to find something better to do. So now that generates some damn good PhDs for somebody, but you say, well, what else are you going to do other than sort of write papers about it? So it makes you think, what else could you do? And you start thinking, hold on a moment, overdose, you're either a medic and you learnt about it, sort of early on, or even if you aren't, you've watched Pulp Fiction. So now, let me hasten to say, that Tarantino got it wrong. You don't need a needle. You don't need a needle that's about 1 meter long with adrenaline in it. But what you do need, of course, is take-home naloxone. You need pre-placement an emergency dose of naloxone. The first time it was seriously considered is getting on for 20 years ago. We've been thinking about it and being pretty slow about implementation. The first time we seriously began to explore this with both patient populations and community samples was back in the late 90s. And essentially what we're needing to look at is, how would you train these different populations? They really need to learn three things. How do you realize that this crisis is happening? Secondly, how do you manage the situation in general in terms of overdose management? And thirdly, if you're going to move on to also give naloxone, how do you do that? They're not particularly difficult training challenges, but there's those three different components. If you want a background film on it, there's an extremely good film that the Red Cross in the UK put together to do with training work by the Red Cross, teaching the management of overdose, putting people into the recovery position, checking their airway, and then also giving an emergency naloxone dose. It's an excellent film. But teach somebody about how to recognize it. Realize that somebody's lips going blue, somebody being unrousable, pinpoint pupils. These are reasons for you to think this isn't somebody in a healthy state of affairs. Then knowing what, the layout's all gone wrong. Knowing what to deal with, how to deal with it. We put it together as basically an ABC naloxone. A for calling the ambulance, B for checking the breathing, C for putting someone into the recovery position. And I know that recovery doesn't begin with a C, but it's sort of, you've just got to go with it. And then give the naloxone. How do you give? We realized that intramuscular injection was obviously the thing to do, not intravenous injection. It's a nightmare even as a skilled medic, or even speaking as myself as an unskilled medic. The idea of giving an intravenous injection to somebody who's spent the last few years messing up the veins that he or she's got, and then whatever veins they had are now collapsed. It's a crazy idea, trying to find a vein unless you're really lucky. Just get it in intramuscularly as quickly as possible. And it's what you would teach the family of somebody who had a peanut allergy or a seafood allergy, or if you were trying to manage status, a family where they knew there was a risk of status epilepticus or diabetes. I mean, it's just applying those same principles of equivalence of right of access to healthcare from that wider health domain to this situation. And I think you have a Parity Act and Parity Law going through at the moment, so it's very relevant. And then we were beginning to think about peer drug users as being the intervention workforce, and then we suddenly realized, hold on a minute, this is far too narrow a view. We are needing to equip a wider intervention workforce. And in particular, it's carers, I think, are the group. Family and carers are the ones that have been strangely omitted from consideration of it. It's what you would instinctively do if you were dealing with the food allergy situation and an emergency EpiPen, and we don't apply that thinking in our area, and it's shameful that we don't. We've looked at your colleagues around you are the best critics. People were saying, well, how do we know that drug users can learn these skills? And you go, well, yes. So we did a study that measured whether drug users learn these skills or not. And with a little bit of mischief, we thought we'd use clinicians as the comparison group. So first of all, we discovered that when we test clinicians and the clients, and we were training both of them in overdose management at the time, and the sort of blue bands, how people scored, how the clients scored before the training, and then the purple is how they scored after the training, and there's the clinical staff working in drug services alongside them, and you think, well, actually, our clinicians don't seem to be any better than the clients they're treating in their knowledge. They were slightly better in knowing what actions they should take. But by the end of the training, our patient population were just as skilled. A warning note, we had lots of people who came out with fancy things like training the trainers and cascade systems of making this more widely available. If you're involved with that, this was a sort of sobering paper that we put together saying, there's no question it works, you can train these people, but actually presuming that it would trickle down, it was disappointing how quickly people got swamped with the bureaucracy of going back to work and then forgetting that this was part of what they were meant to do. With the families work, we then started surveying families about, people said, well, I don't think families would want to know about this, and you just sit there with a sense of disbelief. How could you possibly have a son or a daughter or partner with a heroin problem and say, I don't want to know how to deal with a possible overdose situation? It just doesn't make sense, but colleagues kept saying this, so we started surveying family members. And it was pretty shocking stuff. You do questionnaires and surveys, and you get a bit hardened to it. I have to say, getting some of these questionnaires back brought me up with a bit of a jolt. It included 5 parents who wrote back saying, I've already lost a son or daughter to a drug overdose. I don't want to lose my other one. And also saying, I'm really delighted you've developed a new medicine for treating heroin overdose. I didn't know it existed. How long's this new treatment been around? And a little bit sobering to have to say, well, I don't know whether it's 40 or 50 years, but it's, it's been all of my working lifetime. And almost all of them saying, I'm just hungry to be told how I hope this situation never occurs, but I'm hungry to know how to manage it. And we then looked at family member training. We've got a paper just come out last week, or was online last week, from one of my PhD students. We looked at how well do people, how well do their confidence in dealing with it improve, and how I can't remember which way around it is actually. One of these is their confidence, and one of is their knowledge scores when we tested them on actions that should be done. And 3 months later, not only have those scores improved in the trained group, but they've been maintained at 3 months. It's a pretty cheap drug. If you distribute it, how much of it gets used? Well, if we look at different places in the world that do take home naloxone, about 10% of it gets used in earnest. I think that actually makes it a pretty good value for getting a life-saving intervention out there. And the final few slides, interesting that Matt put up the fact that we need 30,000 people to be able to detect a real difference of a rare event. We're in the early stages of a large randomized trial taking this at-risk population, former heroin users coming out of prison, and we're saying, okay, we don't do anything routinely for them. We have a window of opportunity in history to test whether this makes a difference. At the moment, they're being given nothing except information and a leaflet saying don't. And we are predicting that by giving an emergency take-home naloxone dose and a video for the family to teach mum or dad how to deal with this situation, that there'll be a lower overdose death rate. We started it last summer. We're about 700 subjects now through the randomized trial. We're assuming we're funded to go to the main study. We're only doing the pilot study at the moment. We'll need 30,000. We've obviously done the same sum, so we've detected you'll need 30,000 to be able to detect a significant reduction in the death rate at this critical time. If you want to know a bit more about the study, we've got a paper recently came out describing the rationale for the trial and the challenges in doing it. Dealing with the prison system as your partners in a randomized trial has been quite an interesting experience. It's actually been quite productive. It's gone well, and I'm very grateful to them because we were a bit nervous about that partnership in terms of doing a randomized trial. We give it to people we put the emergency naloxone dose in a wallet so that hopefully they'll have it on them at the time that the overdose occurs. Hopefully the wallet they've got doesn't have my credit cards in it, but has somebody else's credit cards in it. And I'll leave the areas of confusion up in case there's any questions later. So thank you very much.
For Dr. Sprang on his 2 talks, and then I'll make a few remarks, and we'll then have general discussion.
A couple of questions. First of all, in your first presentation, how are those guidelines distributed? And do you dispense all your methadone in pharmacies over there?
Yeah. I think I'm correct. There have been different generations of the guidelines, and I think that those guidelines, which were late 90s, were still in the old-fashioned technology that they were sent to every doctor in the country in what's called the post system. The later guidelines, they all got emails with them as attachments. And I think it coming through the door in the post was actually a better system in my view. They don't have any mandatory legal status, but they are regarded as the norm for what practice should be. So professional regulatory bodies refer to them as a description of normal practice. And so that was there a second bit to it? So one was how are they distributed? Almost all the vast majority of methadone is from dispensing community pharmacies, yeah.
But no specific training, no mandatory trainings?
No.
For docs, okay.
No. Oh, well, sorry, I need to be... if so, it's so light that you might blink and miss it. I mean, I think there probably is some training, but not in the way that you have a much more clearly regulated approach to this. So what we're dealing with there is moving from a system where there was no training and no requirement to gradually introducing it. It's the opposite direct. So whereas I view the US looking at how you can relax the system a bit to have more flexibility, the UK is trying to look at how do you introduce some regulatory control. It's coming from 2 very different starting points.
Right, yeah. The other thing I was going to mention too, some people may already know, but SAMHSA recently has published some really nice guidelines on overdoses for family members and professionals.
Oh, right.
They're online. They're really great.
All right.
I'm curious about how overdose, and particularly opiate overdoses, get investigated in kind of the UK and I guess also in Scotland. In Maryland, there's a state overdose prevention plan that is currently being implemented, and one of the concerns and one of the issues that we've run into is that when opiate overdoses are examined by the medical examiner, if they find 6-acetylmorphine or any evidence that it's heroin, then it automatically gets labeled as a heroin-related overdose and not anything else.
Yeah, that is a problem. I think worldwide that's a problem. The way we addressed it in the first presentation was that looking at coroner's reports or sort of medical reports when deaths have been investigated, there's 2 different categories of report. One is where that drug is the only drug used, which gives you a cleaner picture, but an incomplete count of the number of cases. And then the other way in which you can retrieve the data is where that drug is included and maybe alongside other drugs. And we did both approaches, and in fact there were 2 different lines on the graph, and they showed the same phenomenon whichever way you chose to do it. But it is a problem, yeah.
Thanks a lot for great presentations, and I, of course, really enjoyed how in UK, how you are using data to change the practice, and then you evaluate if you did whatever you intended to do. And my question is, well, I lived for a long time with the idea that in UK, most of the methadone that is being prescribed is being prescribed by primary care physicians. But last last week I met a researcher from UK who was saying, oh, no, that's wrong. Most patients, most methadone patients are being treated in specialized methadone centers. Only a small percentage of methadone patients are being treated in primary care physician offices. So of course I'm wondering if that's correct information, and second, if that is correct information, if you were comparing those two practices.
Yeah, it's actually very difficult to give a clean answer to this. We have always had office-based practice. We've always had primary care practitioners being able to treat people with their addiction problems. So that includes methadone and buprenorphine. They have it's as if you've always had. If you imagine a scenario where office-based practice for methadone and buprenorphine had always existed, that's roughly the situation. But you also have the situation that a lot of medical practitioners don't like doing so. So you've got the problem then about how to get them to accept the role that they should have. And I'm puzzled by what you were told last week. The main, probably what might explain it is the main expansion that's occurred over the last 10 years is of a hybrid response, which is of third sector, voluntary sector agencies working with general practitioners, usually general practitioners, providing the vast majority of methadone treatment and buprenorphine treatment, and specialist clinics becoming pretty rare, to be honest. So perhaps what the person was referring to is that pure general practice, or pure GPs doing it in a GP setting, so primary care practitioners doing it on their own might not be so large, because most of them are working with those third sector agencies. But well over half is now in this less well understood, devolved organizations, which can sometimes be good and sometimes be a bit worrying.
Well, I think we're just going to let the questions go on, and since now we're getting close on time, certainly direct them to Dr. Strang, but if you have general questions, that's fine, and if I don't make any remarks, that's fine too. The important thing is to have communication. So
it would be more the remark. We are talking about overdose as the constant. It had happened. And does it make sense to take a look closer? We know that the best treatment is prevention. What the overdose by itself, maybe do the research to learn what it is. And once we know more about it, what's the dosage could cause it, what kinds of drugs, then it would be easier to deal it. Even our patients learn, their family learn. So let's put it this way. Okay, that much of illicit drug use, you can do it. But above this amount, it could be fatal for you. Doesn't make sense. Because we are not analyzing it by itself.
I can respond to that. The problem is different people have different levels of tolerance. And when we're talking about street drugs, no one knows what the amount of them is. So I don't think that's going to be a big avenue towards helping us. So if you have a comment or question, go up to the microphone. I'm going to just make an administrative announcement before I forget that the program, for some reason, said that this session did not offer continuing medical education credits for physicians, and that's wrong. I'm really happy. It's 3.5 credits, so and everyone else gets the credits that were listed in the program. So go ahead.
I think this is relevant to what's being saying. I worked for about 7 months as a psychiatrist in a local prison, which was about all I could stand. But I used to tell addicts who were about to leave and go out on probation, I'd say, if you're going to relapse, the minute you get a chance to do so, please remember that your tolerance is lower and please be careful. And I gave them a little bit of education about what to expect. And I was called in by the medical director and told not to do that because it created an impression that the Department of Corrections advocated relapse. So I was stopped from doing it. Actually, I didn't stop doing it, I just stopped documenting it.
Well, that, that can be a problem, and that's why Dr. Let's clap. Dr. Strang's study is that he's launching into giving them the Naloxone on prison releases is so great. So I will take a couple minutes and try and tie everything together. What have we learned here today? I think it's not new knowledge, but it's been emphasized to us that we are, the disease that we deal with, opioid addiction, is a highly lethal disease. People may die from overdose, as we've heard, or they may die prematurely from HIV infection, hepatitis C infection, or other medical consequences of the illness. And we've also heard that treatment is very protective, that we can really reduce the risks of mortality, the treatment we provide. We have heard that, as was alluded to by a questioner very early in the morning, the early weeks of treatment are actually among the danger times, and so we have to think about that. But what's even more serious is what we've just been talking about. When people leave treatment or leave prison, that is a hugely high-risk time. And we have these good treatments, but we also have the problem that was demonstrated in the START study. You've already seen this, the dropout rates. We do not keep our people in treatment the way that we should. And when we don't keep them in treatment, we are setting them up for very, very adverse consequences. So we did also hear some ideas about how to better keep people in treatment. Dr. Jacobs talked about the induction trajectories, and it was the data that she was able to analyze from the START study did show that, particularly with buprenorphine, getting the dose up quickly in the very first few days and certainly first week of treatment leads to better retention than keeping the dose low. And luckily with buprenorphine, there aren't any safety concerns about ratcheting the dose up very quickly. And yet we have programs and practitioners that are not doing that, and they're potentially losing some of their patients for that reason. Secondly, she showed a similar kind of finding with methadone. It's a little more tricky, though. In the START study, we were able to get people up to around 90 to 100 milligrams per day in the first month. But there is that concern about going too quickly, and that was raised in a couple of questions. But I think even if the dose is increased every 3 to 5 days, within 28 days, you can get someone from 30 milligrams to the 90 to 100 milligram range, and I don't think we're doing that often enough, unfortunately. And then it's probably for the future a bit, but Dr. Christ presented a very intriguing analysis of pharmacogenetic data that indicates that people with, in this case specifically African Americans, but I suspect there can be other findings if we explore it more. In this case, African Americans with a certain mutation in the gene that codes for the delta opioid receptor are going to have a differential response to methadone or buprenorphine. And wouldn't it be wonderful if we could match patients to the right treatment instead of what we're left with right now is guesswork? Well, maybe I'll put this person on methadone, maybe I'll put this person on buprenorphine, and we don't really have a good answer. So it's nice to know that we're on the trail of being able to do that. And from a very basic science perspective, we know very little about what the delta opioid receptor does. As he said, in opioid addiction, it appears to have a big impact based on his work, and we really need to find out more about that. So I think what we come out with from this symposium is an impetus to really work on trying to improve our treatments. And one of the things we can do now is to be, while being safe, be more aggressive with our medication dosing. And there may also be behavioral, but it wasn't covered here, but there may be specific behavioral interventions we can figure out. I don't think we know them now because although there was some evidence that in the study from Indonesia, at least in that setting, increased behavioral treatments seem to help a bit, but the ones that we've looked at so far, just increasing the dose doesn't seem to make any difference, so we need to figure out smarter behavioral interventions. So I think there's a lot we can do differently and better, and I'm certainly enthusiastic to take what I've learned here and bring it back to the clinic. And with that, I'll throw it open for further discussion. I hope everyone will join in and participate. And welcome, Mark Perino. Thank you for coming in. Everyone's hungry. So if there are no questions, or it looks like the gentleman here might have a question, either that or he's dashing out quickly.
No, I have a question.
Good.
The Italian cohort, the slides seemed to, I wasn't able to study it carefully, but it seemed that the behavioral intervention was even more effective than opiate replacement therapy. Is that what other people see or saw?
There was insufficient, the hazard ratios between the different therapies overlapped. I'm sorry, I forgot to, I will provide all the papers if you want, so I'll give it to Sean. So if anyone wants all the papers that I've referenced or John's referenced, we'll give them to Sean. But no, there wasn't any difference. And the critical thing with that I didn't show is that there's also no difference in the risk of death following treatment. So that makes it even more imperative about the duration of treatment. And the non-pharmacological treatments were all very short.
I have, I guess, a comment and a question. So this has been really fabulous, and I have really, I'm also going to take away a lot of new information and kind of do things maybe a little bit differently. I guess my comment, though, is also that we have a lot of data about, Tom McClellan's study about the randomized methadone versus methadone counseling and other ancillary services. I think this is fabulous data to help confirm and also be able to use to convince policymakers that there is absolute value and there is a need for really restructuring the finance mechanism of opiate addiction treatment from an acute care model to a chronic care model, and whatever that actually kind of implies and means. I guess my question is to NIDA, maybe, and kind of NIDA SAMHSA, is what does it, from that perspective, what are kind of the policy implications and what are the next steps in terms of really taking this data and making those changes that we see on the ground are absolutely needed? Because we run into insurance companies limiting the dosage, limiting the time in treatment. Now, in Maryland, we have now run into a situation where insurance companies are no longer authorizing ongoing methadone maintenance treatment because people are still either using opiates or other substances. So how do we really kind of, as a community and as advocates, really try and use this data to now make some decisions?
Well, I'm glad Petra's getting up since she's the NIDA person.
Okay. But actually, it's... Yeah, actually that's a very good question, and it belongs to this session because this session is based on a blending initiative, which is really collaboration between NIDA and SAMHSA. So whenever now we in CTN or other parts of NIDA have some very interesting research findings that may change the way the practice should be delivered. we talk to our SAMHSA colleagues, we get together and really brainstorm about what we can do in order to help them move such change forward. Because of course we can give them the data, we can give them support and references and research, but it's really their job to work with you guys to make things happen, because we cannot advocate for policy changes. We are research organizations, but again, we provide all the informations and all manpower we can to support SAMHSA in whatever SAMHSA decides to do in the next steps. And we have great collaboration with our SAMHSA colleagues. And of course, we come here every year thanks to ATOT and Mark Parino and his staff, and we really enjoy disseminating information that we have to you guys.
And I would just say we have the same problem in Washington State, that Medicaid patients on buprenorphine are allowed to stay on it at maximum for 1 year. So, and actually you have to get, it's 6 months and then you have to get a renewal. And what we're trying to do is become activists and change that policy on a more local level than a national level. I mean, we certainly have to work from the top down, but we have to work from the bottom up also. So,
in terms of influencing national and state policy, I think it's critical, if possible, to include crime rate data and not just health outcome data. I think when buprenorphine was introduced into France, they did keep, at least they measured crime rates and saw a dramatic drop, and that influences, state and public opinion as well. And to the extent that that could be tracked in some of these studies, I think it would be very, very influential.
Well, thank you again for the presenters, and thank you everyone for coming to this in a self-serving way, I'll say, wonderful symposium, and enjoy the rest of the wonderful conference that's coming up for the next few days.